Good evening, guys. My name is Dr. Kevin Nyachio. I'm an emergency medicine doctor. In this third part of the series, we are going to look at ECGs of concern in patients presenting with chest pain. Straight ahead, let's go on. This will form the scope of my talk. We'll discuss typical versus atypical chest pain, changes on ECG that we will see in patients presenting with chest pain. We'll discuss the different types of ST-elevated myocardial infarction, so-called Stemi, as well as Stemi equivalents, as well as mimics of Stemi in that order. So as we go on, feel free to post your questions, concerns, additions, subtractions, then be able to address them as we go on or even at the end of the presentation. So straight ahead, when you get a patient presenting with chest pain, in the emergency settings, there are certain types of things you need to think about. As you can know, chest pain can be as a result of a number of different things, from externally from musculoskeletal system. You could have rib fractures, costochondritis, herpes zoster can present with chest pain, GI issues, the GERDs, the refluxes. You can have pulmonary issues, pneumonias, hernias, heart failure, valvular issues, especially the aortic stenosis can also present in chest pain. But you need to think of this, what could be the cause, what could be the sinister causes. And in the emergency setting, we tend to think about the emergent causes of chest pain. And there is a rule that I more or less tend to use in my practice. It's called the 4-2-2 rule. It tends to look at the cardiac causes, pulmonary causes, esophageal causes. For the purpose of this talk, we will be more or less looking around cardiac and pulmonary issues, but mostly acute coronary syndrome, but we'll still discuss other equivalents and other mimics. Okay. What I want to emphasize is that when we are evaluating these patients, in addition to evaluating the pain or what has brought them to whichever facility you work at, it's also good to think about what kind of patient you're seeing. Are you seeing a young patient? Are you seeing an elderly patient? Are you seeing somebody who has multiple comorbidities, diabetes, hypertension, dyslipidemias, or somebody who has a significant history of smoking, or they have a significant past or family history, as it were, of coronary artery disease or premature cardiac death. So all of this come into the picture when we're evaluating a patient who's presenting with chest pain. Importantly, again, I think most of us here during our training in undergraduate, we were told about this mnemonic, the Socrates. It comes in handy when you're trying to evaluate the chest pain of your patient, the site, the onset. What kind of pain is it? Is it radiating? Is it alleviated or relieved by whatever factors? What exacerbates it? Is there throughout? Okay, so the characteristic of the type of pain that your patient is presenting will point you out on whether do you think about ischemia, that is acute coronary syndrome, or could be something else. Classically, the type of pain that should point you out to thinking about ischemia, what we call typical chest pain, usually characterizes a discomfort and a pressure rather than a pain. We have seen, or I would say I've seen patients who come and tell you, I feel like there's a stone on my chest. I feel like there's an elephant sitting on my chest. So it's more or less usually a pressure. And this has been there for maybe 2 minutes, 5 minutes. Pain is worsened or provoked by any sort of activity, however minimal. Sometimes you can find that this pain is radiating down the left arm, or is feeling the pain on the left jaw, okay? The pain is there throughout, does not change with changes in position, does not change with changes in while breathing in and out. Sometimes you might find that this patient, they are phoretic, or even when they are speaking, they're not even able to complete sentences. There could be an associated nausea. Some might even vomit, and they'll tell you that if they rest for a bit, just relax a bit, the pain goes away. Or once they're given nitrates, the commonest one being nitroglycerin, the pain goes away. That is typical chest pain. That should point you towards ischemia or acute coronary syndrome, as opposed to their typical chest pain. Usually, most of the time, I think all of us see these patients, the majority that presents to our ED, a pain that is, the patient can actually point to you. The patient tells you, ichungu iko hapa. It can be localized with a finger. Or somebody comes in with a pain that has been there for weeks, for days, comes and goes, is not provoked by any activity. He's able to go about his normal daily activities without issues. Usually says sometimes the pain when I move, when I bend forward, or sometimes when I try and stretch my hand backwards, the pain is worse or the pain is relieved. That is more or less an atypical chest pain. That said, it's always a good idea, or I think I would rather make the clarification here that acute coronary syndrome pain is not only left-sided. I know there's a myth out there that left-sided pain is the one you need to worry about. It has since been demystified that you can also have central chest pain. You can also have right-sided chest pain. You can also have people coming in with just pain in the jaw. So what I'm trying to get at is that sometimes these patients, the way they present is atypical, or it won't really match up to what you are expecting. So you need to have that high index of suspicion. So this is a recap. Nelson and Grace went through this. I like this diagram. I always tell people this is a diagram that changed my life. So it's a diagram that shows you the different ECG positioning, the different, what they represent, which arteries are affected by the different parts of the ECG, both the precordial and the limb leads, and it's color coded. I'd be very happy to share this at the end of my presentation, or you can even just Google it. It's an ECG that it's a diagram that you need to keep at the back of your mind, so that when you are looking at an ECG at first glance, you should be able to know what am I looking at. If I'm looking at, for example, V1, V2, V3, V4, what am I thinking? Which part of the heart is affected? Which vessel am I thinking is affected? And how, before you even start thinking of escalating these patients, involving the cardiology team, at first glance, they should be able to tell you what you're looking for. So usually the left-sided leads, demarcated yellow here, lead 1, AVL. So easiest way to remember, I tend to just put my arm out. Lead 1, again, remember it's on the left arm. AVL, L should be left. Lead V5, V6, again, when they're placed on the chest, they're usually towards the lateral, towards the left side. So these are your lateral leads. Lead 2, 3, AVF, as you can see here, usually towards the floor. AVF, F, I tend to think about it as foot. So 2, 3, AVF, inferior. These are the inferior leads, okay? Lead V2, V3, V4, even as you can see on the placement here, more or less central leads, anterior leads, pteroseptal leads. Then there's AVR and V1. Usually we think of them as the right-sided leads. So patient presents with chest pain. So usually the progression of changes in a patient who is presenting with chest pain, if they truly have an ST elevated myocardial infarction, this is a normal ECG, normal morphology, isoelectric line here, P wave, QRS, T wave. The first changes that usually take place, you start getting these hyperacute, so-called hyperacute T waves. They are wide and tall. It's a good idea, again, to differentiate this type of T waves from the T waves that are usually seen in patients with hyperkalemia. The history itself should be able to point you out. If you find a patient is chronic kidney disease on dialysis, you put an ECG done, then you see very tall and narrow, symmetrically narrow peaked T waves should point you out towards hyperkalemia. So whenever you're hearing a patient is on dialysis, kidney issues, potassium should be at the back of your mind, as opposed to the T waves in myocardial infarction. They're usually hyperacute, wide and tall, and then this usually progresses to now an obvious ST elevation. Usually by the point you are noticing this ST elevation, this is an indicator of onset of myocardial necrosis or tissue death. And this is actually at the point at which we want to intervene. You want to give a thrombolytic drug, you want to do PCI, okay, because you already have ST elevation, and then this progresses to T wave inversions, you develop Q waves, and then ST elevation improves, then the T wave normalizes. That's it, the type of ST elevation, because sometimes you might find an ST elevation but it's not significant. What we tend to look at for is how tall or what type of ST elevation. There's a criteria we tend to look at to be able to identify what we call a significant ST elevation. So in men less than 40 years, and especially in the precordial leads, V2, V3, V4, ST elevation greater than or equal to 2.5 millimeters, that's usually significant. That is in men less than 40 years. In men more than 40 years, ST elevation more than 2 millimeters, again in the precordial leads, V2, V3, V4, is significant. In females, ST elevation 1.5 millimeters and above is significant, or in all of this, when you have an ST elevation of greater than 1 millimeter, I think, in all other leads, and with the absence of ventricular hypertrophy or a strain of the heart, that is the left bundle branch block, that is significant as well. So this is another diagram, should be at the back of your mind, progression of changes when somebody is having an acute coronary syndrome. So most of the time when we look at ECG, we can tell the ST elevations, and then you are able to pick up ST elevations, you're able to escalate early enough to call your cardiologist or the senior colleague on the shift, and then your senior tells you the reciprocal changes, look for them. So most people usually say it's a bit hard if you don't know what you're looking for, but there's a nice mnemonic. Again, this is a diagram that I found on the internet, and I think it's one of the things I usually say that changed my life. So if you are looking at ST elevation, for example, in the anterior leads, you notice ST elevation. This mnemonic, it's called PALES. If you spell it clockwise, it's called PALES: posterior, anterior, inferior, lateral, septal. So if you notice when you look at an ECG, there is ST elevation on the anterior leads. Immediately, you should be able to look at both posterior leads. You should be able to look at the inferior leads, the lead 2, 3, AVF, for reciprocal changes. So if you're seeing ST elevations in anterior leads, you should be able to look for reciprocal changes, not usually ST depressions. For anterior leads, we'll usually look at the inferior leads for any ST depression, that is reciprocal changes. For the inferior leads, for the lateral leads, septal leads, more or less the same. So you look for where you have the ST elevation, and when you have this mnemonic, this nice mnemonic, where you're able to draw it. I usually draw it for all my patients actually, so that I know where am I looking for this reciprocal changes. Again, as with all ECG, as looking with all ECGs, this comes with practice. So the more the ECGs you look, the more you look for these reciprocal changes, the more you look at the ST elevations, you are able to, with time, you're able to make sense. Sometimes you just look at your anterior leads and immediately, ukiangalia inferior leads, you're able to tell there's already reciprocal changes. So the more you practice, the more you see these ECGs, the more it becomes second nature to you. So straight ahead, I want to go to my first ECG. I don't know if people are able to look at this. Tell me, what are you guys seeing here? And what do you think? What is the type of MI here? Maybe I can give you a short history. For example, it's a 50-year-old male, past history of dyslipidemia. He's a chronic smoker. Father and elder brothers died at the age of 55 suddenly. Comes into your ID complaining of chest pain. He's diaphoretic, he's sweating very hard. Then all of a sudden, or at least you're told initially when he was picked by the ambulance crew or whichever, he collapsed, he had a cardiac arrest, but they were able to achieve the return of spontaneous circulation while in the field. They did good ACLS and he was able to wake up. Then he's brought to your facility. First thing, you connect him to the monitor, you connect the ECG, and you see this. So what are you guys seeing? Okay, anterior septal MI. Why is that? Stemi, anterolateral, Stemi, anterolateral, Stemi. So general idea, I think everybody is getting it. We are getting a Stemi. Okay, so as you can see here, there is ST elevations significantly, V2, V3, V4. You can also see a bit about V5, V6. Remember, V5, V6, AVL, as well as lead 1, these are lateral leads. You already have V2, V3, V4, ST elevation. So you're already thinking this is an anterolateral MI. So when you go back to that mnemonic, anterior MI, where do we look for reciprocal changes? Typically in the inferior leads. So lead 2, lead 3, you can see an ST depression already. AVF, you can see reciprocal changes. So I agree, this is an anteroseptal myocardial infarction. We already have reciprocal changes in the inferior lead. From the diagram, the initial diagram that I showed you guys, again, remember, anteroseptal MIs, they are usually affected. They're usually as a result of occlusion of the left anterior descending artery. Okay, so V2, V3, V4 MIs, there's a ST elevation, there's a concomitant reciprocal changes. So we are thinking about the LAD, okay? Significantly, this is usually a very poor prognosis lesion, simply because a large part of the left ventricle is involved. Sometimes the conduction system is involved. So these are patients who you'd want to escalate. As soon as you look at this ECG, you call your senior colleague, call the cardiologist on call, start the patient on aspirin, clopidogrel, ticagrelor, or whatever you have. This is a patient who will benefit from PCI, okay? The goal here is reperfusion. early reperfusion. Remember, when you're talking about myocardial infarctions, we say time is muscle, okay? The more you delay, the more muscle necrosis takes place, okay? So this is an anterior MI. I think most of us were able to get it. Next one. So same patient, 50-year-old, different case scenario, 50-year-old smoker, takes alcohol, history of hypertension, diabetes, not really keen on medication. He's brought in with chest pain, complaining of chest pain. When you connect him to the monitor, to telemetry, you want to take his vital signs. He has a blood pressure of 87/50. He has a heart rate of around 40. Okay, so there is hypotension, there is bradycardia, and then your ECG looks like this. What do you guys think? Okay. I'm seeing people saying, yeah, inferior MI, inferior MI. Yeah, so the general feel, most of us are getting it. It's an inferior myocardial infarction. Remember, we are looking at lead 2, lead 3, AVF, where we can see significant ST elevation. From the diagram again, remember, inferior myocardial infarctions, usually a lesion of the right coronary artery. And sometimes, remember, the right coronary artery again gives off a branch to the AV nodal artery. So AV node, the branch of its supply to the AV node is knocked off. There's a STEMI just before the branch of AV nodal artery. Okay, so that's why you get this, sometimes you can get this first and second degree AV blocks. You can get severe hypotension. And again, these are not the patients where you want to give nitrates, okay? This is a type of MI, if you give nitrates, if you give nitroglycerin, they will develop severe hypotension. Again, significantly, sometimes in inferior myocardial infarction, you can get right ventricular involvement. Actually, I think in around maybe 30–40% of the cases, these patients usually have severe hypotension. So there's usually a criteria that enables us to know, is it just an inferior myocardial infarction, or is there extension to involve the right ventricular wall? And the criteria I know is that sometimes you might find the ST elevation, like here, ST elevation in lead 3 is more than the ST elevation in lead 2. Okay, and sometimes you might find there is actually ST elevation in V1. Okay, so when you're thinking of inferior myocardial infarction, please take note of the kind of changes that you're seeing in your leads. So ST elevation in lead 2 greater than in lead T, you already have an ST elevation in V1, okay? Should be able to point you out there is right ventricular involvement, and then this type of lesion is a fluid-dependent lesion. So these patients would actually benefit from IV fluids. These are not the patients you want to give. These are not the patients you want to give nitroglycerins or any vasodilator, because it will just worsen the hypotension. So observe these patients again. The ED, of course, you've already escalated before to your cardiologist, to your senior. If there are any types of blocks, first degree or second degree blocks, usually the most common one, depending on how unwell the patient is, on how the hemodynamics are, you might require at some point to pace the patients if they are type 2 second degree blocks, so if If the patient is received fluids which are refractory, the bradycardia, the hypotension is refractory. So inferior MIs look for right ventricular extensions, avoid nitroglycerins, IV fluids. Your best friend here, involve the cardiology team as soon as you can. Of course, you've already given your aspirins, your clopidogrels, your atorvastatins, and all that. Okay. Again, yeah, I think that's it. We can go to the next one. What are you guys seeing here? Same patient, 50-year-old gentleman, diabetic, hypertensive, coming with chest pain, and then you put an ECG and you're looking at this. So what are you guys seeing here? Is there any ST elevation? Okay, yes, starting with L2. Twalib is saying starting with L2. Is it an ST elevation or is it a ST depression? So this is, you're saying L2, okay, L2, I agree. There is an ST elevation, okay. V5, okay, I agree. But significantly, what are we seeing here? V1, V2, V3, sometimes in V4. Okay. Remember, when you're placing ECG leads, from the way the orientation is, they are reading the orientation of the heart front to back. So this is a posterior myocardial infarction. Posterior MIs are, in practice and in my experience, they're designed to be missed. So you'd never have, when you do the normal precordial leads, you will have this significant ST depressions, V1, V2, V3. And when you're seeing this, it should prompt you to at least think about the orientation of the ECG leads. So anytime you're seeing this significant ST elevation, especially in these precordial leads, V2, V3, V4, when V1, remember sometimes you can run the whole extent of the precordial leads, V1 to V6. You should have an idea to try and place these leads at the back, at least what we call V7, V8, V9, okay? And when you do that, you would actually find that this depression, when the leads are placed at the back, becomes an elevation. The other thing you can do, actually, when you have this ECG strip, turn it upside down, okay? When you turn it upside down, if you can even turn your screens upside down right now, if you're using your phone, you'll find that this depression is actually an elevation. So when you find that you are turning your strip upside down and this looks like an ST elevation, this is a posterior myocardial infarction, okay? They're designed to be missed. If you don't know what you're looking for, this is how it looks like, okay? You get ST depressions in V1, V2, V3, and when you change your ECG leads to put them in the posterior, what we call V7, V8, V9, this depression becomes an ST elevation, okay? Posterior myocardial infarction. Let's change the clinical scenario a bit. 70-year-old female, elder brothers died suddenly, no cause was able to find out. Hypertensive, but not really keen on medication. Again, comes in with chest pain. Okay, Eva is saying ST elevation in lateral leads. Lateral leads, Nigani. Remember, lead 1, AVL, V5, Well, there is, you can see kidogo, but it's significant in LVL, significant in lead 1, V5, V6, okay? So when you are thinking about lateral leads, so this is a lateral MI, okay? So what are you, where would you expect reciprocal changes, or are we seeing any reciprocal changes here, around here? We've already identified ST elevations lead 1, AVL, V5, V6. We know it's a lateral MI. So where do we expect reciprocal changes? You can see here, lead 2, lead 3, AVF. So the inferior leads are already showing signs of reciprocal changes. So this is a lateral MI. Significantly, it's very hard to get an isolated lateral MI. They're usually in cohort with anterior MI. So you get an anterolateral or an inferior-lateral or an inferior-posterior lateral, okay? Rarely would you get just an isolated lateral MI, but if you do get, again, it is still an MI. So you have to escalate it. You have to inform your colleagues at once. Time is muscle. So lateral MI. You guys are doing good. I'm saying, yeah, inferior leads, yes, inferior leads. Next one, 72-year-old gentleman, smoker, not hypertensive, not diabetic, history of chest pain for the last 3 days. It's persistent with diaphoresis, comes in, sweating. Vital signs are more or less the same. You connect him to the ECG machine, then this is what you see. So what do you guys think? Is there any ST elevation? Is there any ST depression? Is there a certain lead that usually has ST elevation, ST depression, but now it has an ST elevation? Somebody has got it. AVR, okay. A couple of guys have got it. So you are noticing this ST elevation in AVR, okay. You're also noticing there's another ST elevation here, though more or less the same in V1, okay. But significantly, at first look, you will notice there's a widespread ST depressions, okay. V3, V4, V5, V6, okay. Lead 1, lead 2, lead 3, AVF, there's significant ST depressions. At first look, when you look at this ECG, even before you notice this AVR, you have to notice these significant depressions all through most of the limb leads. These depressions, most of the precordial leads again, these ST depressions. So this is usually what we call an AVR STEMI. There are two mechanisms. An AVR STEMI, it corresponds or it represents two types of mechanisms. One, it could be just diffuse subendocardial ischemia, okay? And this is actually usually the most common one, where you get ST depressions in lateral leads, okay? And you get reciprocal changes in AVR, which is the depression. This is the most common one, okay? Or you can get an isolated ST, you can get an isolated infarction or an isolated STEMI, as it were, of AVR. Usually that represents an infarction of the basal septum, so the lowermost, the base of the septum. Remember, the septum, the base of the septum is usually supplied by a branch, just a first branch of the LAD. So if the ischemia or the infarction is proximal to this first branch, so the basal septum does not have any supply, okay? These types of lesion usually correspond to obstruction or stenosis of a left main coronary artery. Even before it gives off the LAD, it usually gives us a proximal branch to supply the basal of the septum. So by the time you're having a base AVR STEMI, this is what you call an Lmca lesion, left main coronary artery lesion. Sometimes you might find the proximal part. Remember, like I told you, the left main coronary artery gives off, before it gives us the LAD, it gives us like a like a small perforator artery to the base of the septum. So it can either be the Lmca, it can be the proximal part of the LLD, and again, it can be triple vessel disease, okay? All of the vessels are involved, okay? So most of us actually got it. So this is an AVR STEMI. You will notice it as significant widespread ST elevations all through limb leads, precordial leads, and significantly you will have ST elevation AVR. It is an MI. Okay, so we've talked about these types of NMI: anterior, inferior, posterior, lateral, AVR. There are other types of MIs where it might not be as obvious. When you're looking at ECG, it might not be as obvious as an MI, but it still represents a STEMI. These are what we call STEMI equivalents, okay? So from here on, we are going to discuss about STEMI equivalents. So the first one here, I think it will be best if I give a clinical scenario. 50-year-old gentleman has come in, not currently in chest pain. I repeat that, he's not currently in chest pain, but for the past 3 days, he's been having chest pain on and off, okay? So he gets these episodes of severe chest pain, he has to stop what he's doing, he has to rest, okay? Then it goes away. Then it comes back as a severe chest pain, okay? When you connect him to the monitor, more or less vital signs are the same, are normal, sorry. And when you connect him to the ECG machine, you're not really seeing ST elevation. It could be there, but it may not be as obvious, okay? But what you're seeing is actually in V2, V3, we get this. Goes up, goes down. Goes up, goes down, okay? T wave goes up, goes down, what we call biphasic T waves. Anybody have an idea what this is? It's a STEMI equivalent, okay? Somebody has an idea, okay? Wellens syndrome, good. So this is actually Wellens type A, okay? Significantly, like I've said, the patient could be asymptomatic, okay? But classically, what we need to know when you're thinking about Wellen is the history. Patient comes in, history of chest pain on and off. By the time they're coming to you, they may not be having pain, but there is history, significant history. When you ask for risk factors, smoker, high blood pressure, age over 50, dyslipidemia, the works, okay? Comes in, not in pain, but again, your alarm bells are up because he has all the risk factors for heart disease. Do an ECG, you get what we call biphasic T waves, especially in V2, V3, but this may actually extend throughout the precordial leads. It might span all the way from V1 to V6. Yeah, the history is usually the giveaway for this. Chest pain on and off. By the time they're coming to you, they don't have chest pain. But usually, what I like to think is if a patient has come to you with chest pain, even though it is a retrospective history, that pain must have been significant. For them to come to you, even if they are not in pain, that pain must have been significant. Please have this at the back of your mind. Wellens type A is where we tend to see this biphasic T waves. And again, at the top of my list as a STEMI equivalent is because Wellens it causes critical, what we call critical stenosis of left anterior descending. The few cases I've seen, and from the studies we have, when you have Wellens, the kind of stenosis you have is usually more than 70–80% of the left anterior descending artery. So this is critical stenosis. Please have this at the back of your mind with that significant history of chest pain on and off. Patient doesn't have to come in with chest pain. They might be completely asymptomatic, but when you see this, what we call biphasic T waves, escalate as soon as you can. If you're not sure, always a good idea. Call your cardiologist, consult your senior, have the patient taken care of properly. So this is Wellens type A, biphasic T waves. There is a type B Wellens, where rather than having biphasic T waves, you have what we call T wave inversions, especially again in the precordial leads. Okay, so you can see very nice T wave inversions. Okay, history is the same, chest pain on and off, currently asymptomatic, not in chest pain. Wellens is STEMI, as simple as that. Wellens is a STEMI. It's the easiest one to miss, because for most people, when you look at this, you're not really thinking about a STEMI, but this is a STEMI. With that history, with those risk factors, and with the ECG showing you biphasic T waves or inverted T waves, think about Wellens. If you actually get a chance to repeat ECGs for this patient within the next maybe 30 minutes to an hour, if the patient is not already in cath lab, if the patient is not already thrombolized, this actually goes up. Okay, this actually becomes a proper STEMI. So if you give it time, which you should not, this should actually will eventually become a proper STEMI. Now you'll see a proper ST elevations spanning through V2, V3, V4. That is Wellens syndrome. This is Wellens type B. Type A is biphasic T waves. Type B is a T wave inversions, especially precordial leads. So the other STEMI equivalent. Okay. So what are you guys seeing here? 50-year-old patient, chest pain, they are phoretic, pain radiating to the left arm. They're saying they're not able to breathe, they're hypertensive, they're dyslipidemia. What are you guys seeing here? And what do you think this is? Okay. Somebody is saying picked T waves, which are symmetrical. Okay. I agree. Some picked T waves here. What else? Somebody is saying ST depression in V456. Okay, there is subtle ST depression. I agree. When you tie that up together, okay, somebody is saying picked T waves, hyperkalemia. Okay, I tried to make it. I'll still try and differentiate the T waves of hyperkalemia and the T waves of SES. But in a nutshell, these are what we call the winter T waves. Okay, the winter T waves represent an anterior myocardial infarction. So you get this very tall, prominent, symmetric T waves, like somebody else has just said, in the precordial leads. You can actually get an upsloping ST depression. So you get this ST depression, then upsloping. Okay, ST depression, upsloping into a prominent symmetric T waves in the precordial leads. Okay, sometimes you might get a very subtle ST elevation in AVR, kidogo sana, but you can still see it. Okay, a subtle ST elevation in AVR, significantly if it's more than one box or two boxes, that's maybe more than 0.5 millimeters, just a subtle upsloping of the ST in AVR. These are what we call the winter T waves. They represent a STEMI. They represent an anterior myocardial infarction. When you see this, think about LAD occlusion. The winter T waves, again, myocardial infarction. This is a STEMI equivalent. No question asked. When you are seeing this, this is an MI. Okay. Together with when you're tying down your history, think about MI. If you're thinking about it, if you're suspicious about it, if there is that sixth sense at the back of your mind that is prompting you, patient has come with chest pain, you are seeing this very tall, prominent T waves in the precordial leads, and then significantly you get this upslurring ST depression into a T wave. Upslurring, you see, ST depression, then upslurring into a T wave. These are what we call The winter T waves, they represent an anterior myocardial infarction. This is occlusion of LAD, left anterior descending artery. So the next one, and I would like us to pay attention to this. This could be a bit different from Wellens, but the history is more or less the same. Where you get a patient who comes in chest pain, within a few minutes, no pain. So it's like an oscillating pain, comes and goes, comes and goes, comes and goes, okay? When you, during the episodes of pain, if the patient is on continuous telemetry, is on continuous ECG monitoring, get these ST elevations, lead 2, lead 3, okay? Or even in the precordial leads. Within 2 minutes, patient is not in pain. You're not given anything to, then ECG looks like this, very normal, okay? So you have this pattern of ST elevations that could be similar to an acute STEMI, okay? And then you get reciprocal or isolated reciprocal changes, ST depressions during the episodes of pain. During pain, ST elevations with reciprocal changes. After a minute or so, pain goes away, ECG normalizes, okay? What do you guys think this is? Myocardial ischemia, versus spastic angina, okay, it's a good one. Versus spasm. Yes, I agree. Okay, so this is what we call Prinzmetal's angina, or coronary versus spasm. So we get the coronary artery as the spasm, so you get pain, no pain, pain, no pain. It may be impossible, actually it is impossible to differentiate this to differentiate a STEMI from coronary versus spasm. So you can't make that diagnosis that this is coronary versus spasm, because ECG at one point looks like a STEMI. After a few minutes, very normal, okay? Classically, and what I would recommend, if you're seeing this, treat it as an MI, let the patient be escalated, let the cardiology team be involved. If they go for angiography and they find the vessel is clear, then they can safely say this is coronary versus spasm. But this is not a diagnosis that you'll make in the ED and say patient has Prinzmetal's angina, pain medications, aspirin, go home. Okay, remember patients don't read books. Could be Wellens, it could be STEMI, okay? So as long as you're seeing ST elevations and you're seeing reciprocal changes, even if within 2 minutes ECG normalizes, escalate these patients. Let the cardiac team, let the cardiology team see these patients, let them determine whether this is a vasospasm or it's a STEMI, okay? Because it is impossible to differentiate these two conditions based on ECG alone, okay? But you might find that unlike in STEMI, the ECG changes here usually transient, like I can say, usually they're reversible with vasodilators. You give nitroglycerin, patient is fine. Anarudi sawa. Okay. So Prinzmetal's angina escalate. Okay. Let the seniors, let the cardiologists determine after angiography whether this was truly a STEMI. Okay. You don't want to have to make that decision that you decided for the patient this is an angina. Send them home. Next one. Chest pain patient. 60-year-old male comes in complaining of chest pain. It's not so much, but it is still chest pain. It was brought him to the hospital at 2 a.m. Okay. He says sometimes he feels like there's a feeling of doom, like he's about to collapse. Vital signs are normal. You do your ECG, then you find this pattern. What do you guys think? So we've moved from STEMI equivalent. We are now into what we call Stemi Mimics. So these are ECGs where they mimic ST elevated myocardial infarctions, but they're not truly myocardial infarction. So they're called Stemi Mimics. This is the first one. Comes with pain. ECG looks like this. Vital signs are okay. When you look at the ECG, Typically, Qrs complex duration is more than 120 milliseconds. You note a very dominant S wave in V1, V2. You note very broad R waves in the lateral leads, lead 1, AVL, V5, V6, okay? So when you tie it together, what do you think this is? Dominant S wave in V1, prominent or broad R waves in the lateral leads. Somebody is saying a second degree heart block. Let me have a look. Okay, when I look at lead 2, sure, I tend to agree as well. But this is what we call a left bundle branch block. Well, in the past, or in practice, I think up to recently, an LBBB represents a STEMI. Okay, there is a criteria. There is a criteria, however, because sometimes LBBBs may mask ST elevated myocardial infarction. Okay, up to recently, we used to treat LBBBs as myocardial infarction, straightforward. Okay, but right now, I think the science has shown us in addition to having the criteria for LBBB, the dominant S wave in V1, the broad R waves in the lateral leads, the absence of Q waves. I think in lateral leads, hakuna Q waves kabisa. So you have the criteria for a left bundle branch block. But do you want to know whether there could be a concomitant myocardial infarctions? And this is actually where we have a very tough name called as Gabosa, what we call as Gabosa criteria, which comes in here to be able to differentiate this LBBB from a myocardial infarction. Very scary name. It's Gabosa. Okay, so the criteria has 3 points. So anytime you have concomitant ST elevation greater than 1 millimeter, by concomitant we say the R wave and the T wave are concomitant. They're on one side. Okay, so there's concomitant ST elevation greater than 1 millimeter. That is 5 points. Okay, or there's concomitant ST segment depression. Okay, especially in the V1, V2, V3. So you have this going down. You have the ST segment again going down concomitantly. Okay, greater than 1 millimeter, as you're seeing here, in especially V1, V2, V3. This is, you assign these 3 points. And the third criteria is you have discordant ST segment elevation. So you have this one is going down below the isoelectric line. The other one, the ST elevation, ST segment is going on the opposite side. They're discordant. Okay, more than 5 millimeters. The discordance is more than 5 millimeters in any lead. Again, give a point of 2 points. Okay, by the time you're having 3 points, this is a total of 10. By the time you're having 3 out of 10, that is an MI. Okay, if at first glance, or if you look at this LBBB and you're seeing the concomitancy, whether the concomitant elevation or concomitant depression is more than 1 millimeter, if you're already seeing that, that is an MI. Or if you notice the discordance is more than 5 millimeters, usually the concomitance is what we tend to see a lot. More than 1 millimeter, that is 5, that's an MI. Okay. ST depression concordance is more than 1 millimeter, that's an MI already. Okay, but I've not seen a discordant one recently, but usually by the time you have any one of these, because usually the ST elevation and concordance is more than 1, sorry, that's 5 points, so that's an MI. This is what we call this Gabosa criteria. It's a very challenging thing, I would say, even for me. Every time I have to look it up. Okay, it's something, again, by the time you're mentioning to the cardiologist, they'll give you an ear. By the time you're umefika hapa kusema Gabosa, your cardiologist is already listening keenly. Okay, if this is an exam, by the time unaulizwa as Gabosa, you're doing well. Umepita hiyo mtihani. Okay, So LBBB with Gabosa criteria positive, some myocardial infarction. LBBB alone is a Stemi Mimic. But you have LBBB, please do your Gabosa. Okay, there's a nice video on YouTube. If you just Google it up on YouTube, you'll find a very nice video explaining the criteria. Or if you take time and do this, okay, you should be able to make your decision easily for you. Okay, on to the next Stemi Mimic. Oh, this one is a 19-year-old boy. He's an athlete. He comes in complaining of chest pain. It's a dull pain, left-sided. Sometimes it's there, sometimes it's not. But this time, however, it has persisted for the last 8 to 12 hours. No comorbidities, no family history of heart disease, not a smoker, has never drunk alcohol, no diabetic, no hypertensive. He's a young patient, okay? Vital signs are okay. Pain is tolerable. Pain score 2 out of 10. You do your ECG, you see this. So what are we saying here? Anyone have an idea? Somebody saying normal bronchitis, inferior MI. Somebody saying peaked T waves, ST elevation in the inferior leads. Somebody is looking really keenly and now some ST elevation in the inferior leads. So let me shock you. This is what we call a benign early repolarization pattern. Okay, most books will see it abbreviated as BER. Okay, it's usually in the young. So what you tend to see is what we call concave ST segment elevations, especially in the precordial leads again. Concave ST segment elevation. You see it sliding up. It's a concave shape, especially V2, V3, V4, V5, V6 again, as well as limb leads. You can also see it as well. Concave ST segment elevation. You might see something here at this point, at the J point. I think it's actually most of it. In lead 2, in lead 3, you can see something there. I think there's also in V5 again. But usually it's more or less the inferior leads. Lead 2, 3, VF at the J point. There's something happening, what we call a J point notching, okay? Usually in the inferior leads. So we get a J point notching. You have these concave ST elevations all over. Sometimes you might be able to calculate, if you're able to, you find the T-wave ratio. But this is a bit deep. T-wave ratio is less than a quarter of the V6. So this is what we call benign early repolarization. These are young patients, okay? In their 20s, in the early 20s, less than 20, chest pain. Again, on and off, it's tolerable. Of course, if you do troponins, you have the luxury of doing a troponin, comes back normal. You should be able to cement your decision, but there's nothing really wrong here. This is a benign early repolarization pattern. Again, if you're still thinking of in STEMI, do troponins. If they come back normal, cement your decision. Usually in the young, you should not be able to make this diagnosis in somebody above 40 years old who has this pattern. Always do troponins, always escalate to your seniors, to your cardiologist. So benign early repolarization pattern. History here, it's a 42-year-old or 30-year-old male has come in with very sharp chest pain. This pain is worse when akilala, when supine. It is improved when he's sitting forward or sitting up. Okay, he's had a flu recently, or he's asthmatic, has had recent exacerbations of his asthma. Chest pain worse on movement, relieved when sitting up or bending forwards. When you put your stethoscope there, you're able to pick up some sort of harsh sound, what we call a friction rub. Okay. In addition to this, when you look at the rate, sometimes you might find a sinus tachy, could be because of the pain. Okay. But when you do an ECG on these patients, you have this widespread concave ST elevations. Okay. You have PR depressions, I think, in most of the limb leads as well. You have reciprocal changes again, reciprocal ST depressions and PR elevations, but significantly widespread ST elevations and PR depressions, I think, in most of the leads. 2, 3, you can see in AVL, you can see in AVF as well, all through the precordial leads, V2, V3, V4, V5, V6, and the history. Okay, I think this was rather obvious. This is acute. Pericarditis is another Stemi Mimic. Okay, that's it's always a good idea to involve the cardiology team. Treatment here is usually colchicine and non-steroidal anti-inflammatory agent. Remember, if your patient is asthmatic, you might be you want to think about the type of NSAID, or if any at all, that you're giving to this patient. Okay, so acute pericarditis, another Stemi mimic. Sharp chest pain associated with movements. There's a pericardial friction rub when you listen to your chest. And then ECG, widespread ST elevations, widespread PR depressions, some reciprocal changes. There might be a tachy, could be because of the pain and all that. Okay, acute pericarditis. Okay. This one is straightforward. You shouldn't be able to make this. It's a Stemi mimic. 60-year-old lady. She's a widow. Her husband died on her husband died on the 21st of April 2004. Every year around 20th to 26th of April, she comes in with chest pain, typical chest pain. Okay. Oh, recently she lost a child. Recently she lost her husband. She comes in with very severe chest pain. Sounds like a typical chest pain. History is significant of recent emotional distress, or somebody had invested something, pesa ikapotea yote. Ikaenda hivyo, they have no savings. Okay, so there is history of significant emotional distress. Okay, when you do the ECGs, you see these changes. These ST elevations here, here, here. When you do cardiac enzymes, they are a bit elevated. Sometimes even you might go as far as doing echoes. You find what we call regional wall abnormalities, regional wall washing abnormalities. Okay. On angiography, you're not finding anything. Most of us are seeing. I think this is one of the commonest things we tend to see in the movies, or the series we see in the Grey's Anatomy and all that. This is Takotsubo cardiomyopathy, or stress cardiomyopathy, also known as broken heart syndrome, literally. Next, 50-year-old man comes in with severe, describes it as a feeling of tearing chest pain. Pain is going to the back. You've given paracetamol, you've given tramadol, you're on the verge of giving morphine. Pain doesn't seem to be affecting. Whatever you're giving is not even touching him. Okay, pain is out of proportion. Okay, and when you are looking at his ECG, you're seeing this. What are you guys seeing here? Is ST elevations, is ST depressions. Okay, patient is still complaining of pain. When you try and take his blood pressure, maybe low, it may be high, it may be normal, but significantly tearing chest pains, radiating to the back, pain out of proportion. Okay, and when you're doing an ECG, you get this widespread, sometimes widespread ST elevations, widespread ST depression. Okay, most of us have got it. This is an aortic dissection. Most commonly, in most aortic dissection, the most common feature on ECG is ST depressions, widespread ST depression. Usually, when you're doing ECG, you are more or less seeing complications of the dissection. Okay, so you're seeing an MI. Okay, common presentation on ECG is ST depressions. I think up to 30–40% is ST depression. ST elevations, not so much, could be up to 10%, but it's still there. Aortic dissection, okay? It's something to have at the back of your mind. Tearing chest pain, radiating to the back, you are giving medication, whatever you're giving is not touching the patient. Aski kitu. Okay, so pain out of proportion, should be able to think about this, okay? Sikila siku, myocardial infarction. So if you're thinking about this, an aortogram, of course, you've consulted your seniors, you've consulted your cardiologist, cardiothoracic surgeon, okay? Aortic dissection. Somebody is asking, display the previous slide, the Takotsubo. Yeah, it is. The ischemic chest pain, you have ECG changes, cardiac enzymes may or may not be elevated. Echocardiography will show all changes. Takotsubo. Aortic dissection, tumemalizana nayo. Next one here, 50-year-old lady. She has breast cancer. She's recently failed chemotherapy. She's currently on second session of radiotherapy. She's not able to move, really, more or less bedridden. She has a helper. Comes to you quite tachypneic, quite tachycardic, feeling of difficulty in breathing. Saturations are in the early 80s, okay? Complaining of pain, complaining of difficulty in breathing. When you're assessing them, they are obviously in respiratory distress. They're obviously breathing fast and heavy, okay? When you do the ECG, this is what you're saying. History, from the history again, just from the history, well score, high-risk patient has chronic malignancy. She's not able to move, so she's more or less immobile. Okay, difficulty in breathing. So she ticks all the boxes for pulmonary embolism. You score her on well score. She scores very highly, do CTPA. But before you do the CTPA, there's an ECG done. This is what you're saying. Okay. So in pulmonary embolism, the most common feature in ECG is a tachycardia. It's a sinus tachycardia. Okay. There's what we call the common one. I think we used to be examined on this a lot in school. The S1, Q3, T3 pattern. It's there, but it's more or less, I think, literature. I've not seen this actually in my practice, maybe one or two, but it's not the most common. Again, the most common thing in pulmonary embolism ECG is a sinus tachy. Okay. Yes, you may have S1, Q3, T3 pattern. Yes, you may have features of right bundle branch block. You might have the axis of the heart all the way showing a right ventricular strain. Axis of the heart is plus 180. Okay, you might have T of inversions like you're seeing here. In the precordial leads B1 to B4, there's a right axis deviation here. This already should be telling you that these are features of right heart strain. Okay. You should not delay this patient's management in confirming the diagnosis of pulmonary embolism in starting your lower molecular heparin. Pulmonary embolism, what I want to get across, sinus tachy is the commonest feature. S1, Q3, T3 is good to know if you are able to look for it, but more or less, most of the patients we tend to see don't really have this. They have sinus tachy, they have features of right heart strain. Pulmonary embolism. Okay, last one. I think this will be our last slide. So here we have a 40-year-old gentleman recently diagnosed to have pulmonary tuberculosis. Comes in here with difficulty in breathing. His blood pressure is low. When you listen to his heart, you're not able to pick up your very distant heart sound. Or the skill is really, when you're looking at him, when you're examining him, You're seeing a very prominent pulsation in the neck. When you have an ECG, this is what you are seeing. Okay, known to have TB, comes in difficulty breathing, hypotensive, very faint heart sounds. You even have to borrow multiple stethoscopes to be able to listen to that heart. Okay, there's an obvious JVP, jugular venous distension. Okay, the three signs, the so-called Beck's triad. Okay, in the setting of TB. Okay, most of us are getting it. This is a cardiac tamponade pericardial effusion. I used TB because in our setting, TB pericarditis is the most common cause of pericardial infusion. So imagine there's a lot of effusion there. The heart is literally swinging inside the pericardial sac, which is what we are seeing here. Okay, your very low voltage complexes. Okay, very low voltage QRS amplitude. This is because there's a lot of fluid. So as the fluid increases, QRS amplitude diminishes, and then when you have this, inaenda chini, inaenda juu. So there is a swing. Okay, your heart is literally swinging. Okay, so you have this alternating QRS complexes. One is high, one is low. So your heart is swinging in fluid, what we call the so-called electrical alternance. So this is swinging of the heart in the pericardial space, typically seen in cardiac tamponade pericardial effusion, especially massive pericardial effusion is actually where you will be able to see and appreciate this electrical alternance. Take any questions? I'm seeing Twalib is asking about the delta wave and the Brugada syndrome. Delta wave, Brugada syndrome. We'll speak about this. Twalib, I think my colleague, my classmate, Dr. Jean Wanzema, in the final series next week, will be able to discuss and share what we call the must-know ECGs in the ED. We'll be able to point out about Brugada syndrome, the delta wave, and all those other ECGs, including ECGs of hypokalemia, all of those electrolyte imbalances, and what I've not talked about here. But in summary, my talk today was to be able to talk about chest pain ECGs. In addition to just knowing how ECG looks, in addition to be able to identify the pattern, it's a good idea to be able to classify your patient, see how your patient is presenting, what are the risk factors, what type of pain. The Socrates is quite important to be able to classify typical versus atypical chest pain. The way your patient is presenting, their history, their family history is quite significant. So you have all of these things at the back of your mind. Somebody is asking about the PALE cycle. Just Google, when you Google PALES ECG, it will bring you this nice thing, okay? So finally, in addition to this, remember there is a what we call NSTEMI, non-ST myocardial infarction. Your patient might have very normal ECGs, they have chest pain. If you have the luxury, if your lab is able to do troponin, high sensitive troponins, they come back elevated, it's still an MI. The fact that it doesn't, your ECG doesn't meet criteria for myocardial infarction doesn't mean it's an MI. If you're still thinking at the back of your mind, if your patient ticks all the boxes for an MI, or the risk factors, despite the ECG, always do a troponin. It's always a good idea to get correct diagnosis. Always involve the cardiology team or your senior if you are even thinking about it. If you're suspecting, if you have that sixth sense, escalate this patient.